Welcome to TriloTalk. This is a podcast dedicated to topics that we think are important to the profession of medical writing. And our goal is to bring these topical issues and ideas to the forefront and spark conversations in the medical writing community.
Hi everybody, welcome back to TriloTalk. I'm Chamberlain James, Senior Partner at Trilogy, and for this episode, I'm delighted to be joined by Maureen Kashuba, who's a Senior Director, Head of Health Literacy Medical Writing, and Elizabeth Brown, who's Head of Clinical Transparency, both from Merck. We are going to chat today about all things health literacy and communication. Great to see you, Maureen and Elizabeth. Thank you for joining me.
Thanks for having us, Lisa. It's a great topic and one we're really passionate about.
I know, I can't wait. This is going to be the best bit of my morning. So let's start with the problem. There is an obvious gap between patient comprehension and the information and material that they're given. So do you guys have any classic examples of when wording causes confusion in consent forms or medication guides or anything, any of your nightmare scenarios that keep you awake at night?
There's one that always I kind of start with, and it's been a sticking point for me for the last few years, and it's the difference between study and trial. We often use these interchangeably in industry and clinical research, and they have really different meanings to people. One is studying for a test, another is trial in a courtroom. And they have sort of across the board, there's a lot of different perspectives on how they resonate with people's lived experiences. And we may think we're being more clear by saying study because it seems more understandable. So in some of the workshops we've run in our organization over the last 5 years, we ask this question in every single one. And it always amazes me that we get different answers every time we ask. Some people prefer one over another. And I think it's really important to just listen and learn and embrace what that feedback is and do your best to try to navigate through it. But I think one of the most important things we've tried to do over the last few years is really be consistent. So if we've chosen one way of explaining it, really try to be clear and consistent through all the materials.
I love that example. Go ahead, Elizabeth.
Yeah, the consistency is the piece, because when you see the same word, different word being used in different ways, or different word being used in the same way, that's where the confusion comes from. So, the one that comes up in my mind is study drug and study treatment. Are these different things? Are they the same thing? Study medicine, is it the same thing or different thing? And so that consistency is really important so that patients can understand in the first use and then see it applied in different ways. So yeah, I think consistency is where it is for me with the examples that we have, because there's no right answer in a lot of cases. In a lot of cases, it's preference, and the answer might be better in certain circumstances than others. So it's picking one for the right reasons, intentionally choosing an answer, and then moving forward with it.
I think they're brilliant examples, and I couldn't agree more. And I think it's preference, which is obviously also influenced by cultural influences, societal influences. So, what you said about just listening and learning, I think is great, Maureen. The other aspect, of course, that we have to think about is that although in regulatory world we write in English, but our documents, particularly patient-facing ones, are all going to be translated. So you can imagine for yourselves, we have in English a trial, which can mean like a study trial, or as you said, a defendant with a judge and jury. But in other languages, there is a specific word for each of those things. And if that's mistranslated, that can cause all kinds of problems. I mean, another example that I have is when on your side of the pond, Maureen and Elizabeth, there's often you use the word shot to mean a vaccination, which is totally perfectly understood, but you can imagine how that could be translated and the nightmare scenarios that could lead to. I've also been writing patient information for diabetes trials, and instead of placebo, they wanted to write sugar pill. And in some contexts, that's fine. But in something like a diabetes trial, if you say, oh yeah, one group's going to be given a sugar pill, that's not going to translate as placebo. So it's, I think you can get yourself in real hot water with that kind of thing.
even though we look to embrace consistency, you have to have some adaptability. So we have to allow people to adapt the language so it's culturally appropriate. So for instance, I know you in the UK, they may use the word jab. That
Yeah.
means a boxing term in the US. We often talk about double-blind trials, but in a ophthalmology trial, that could be really offensive. And so we really do need to think about the audience. While we do want consistency, there has to be a space to really talk about how do we meet people where they are, and not offend them, and not just because we always say it this one way. There has to be some flexibility in the way we communicate with patients and the public so that it really, embraces them where they are.
Absolutely. I think plain language and health literacy is so much more than just swapping a vocabulary out. There are so many more nuances and contexts that you have to bring to the table and understand before you can really do this appropriately. I completely agree. So
and the cultural sensitivities are really intense too. So when we listen, we have to listen to a diverse voice and leveraging those experts globally and universally across different populations. We've actually had a lot of success in working with that translation piece that you mentioned, Lisa, of looking to global colleagues and having them help us translate and then look back of, did the meaning come across in the translation, and building that kind of expertise into the process so that when we go back to the English, is this the right word choice because it's globally acceptable to multiple different cultures?
Yeah, absolutely. And so I guess, I mean, aside from there are some comical and humorous mistakes that could happen with word choice, there are some real world consequences of poor health literacy. It's not just, there are cultural aspects. There are proper real world consequences. What are the ones that concern you the most, that you think everyone should really have front of mind?
Real world, I think we see it in our own world. So in our own lives, you can see even poor health literacy in our families and our communities, and you see it in doctors' offices. You can see the confusion on people's faces. But I think, in the clinical research space, there are so many people that aren't engaged in clinical research because they don't understand it, because they don't feel like it's meant for them. And I think that one piece of low and limited health literacy in underserved communities, underengaged areas, even in regions, parts of the world where low health literacy affects over 90% of the population. We need to do more, I think, as an industry and as a clinical research community to really find out what the need is and how can we better communicate with those regions and communities, because we're not reaching them, we're not engaging them in the right way, and so they're not a part of the answer. They're also not a part of improved health. And I think there's a tremendous opportunity for us to think differently about how to reach people that have not typically been part of the clinical research space.
Yeah, and you're touching on diversity, equity, and inclusivity, of course, which I know is another topic that we all feel very, very strongly about, and actually probably should be another podcast episode to dig into that. So I think that would be really good to do in a little while. But yeah, you're absolutely right, and I think we all have our own personal experiences of this. I know certainly as soon as any of my neighbors found out what I did for a living, not that I think they really understood entirely, because nobody knows what a medical writer is, but they knew it was something to do with information and something to do with patients. And I remember one of them, he'd been taken into hospital. He's actually diagnosed with GBS, Guillain-Barré syndrome, which is a relatively rare occurrence, but it happened to him, and he was in a bit of a tiz about it. And I went up to see him to see how he was doing, and he handed me this leaflet, and his hands were shaking, literally shaking. And he said, this is meant to be for me. I'm meant to understand this, and I don't understand it. What am I going to do? The doctor's coming to ask me which treatment option I want. And he said, I don't even know what a treatment option is. He said, please, can you help me? And the guy was almost in tears because he was terrified. He wanted to have some input into his treatment. He knew the doctor was coming, but he'd been handed this leaflet, and I read it. Honestly, it was shockingly bad. I mean, GBS is a hard syndrome to kind of explain anyway, but anything to do with neurological symptoms and neurological effects, you can imagine how hard that is to get right. And they really had not got it right at all. And yeah, I mean, there were words that were sentences long, and yeah, the poor guy didn't have a chance. And it really struck me at that point, what would he have done? Like, what do you do? I mean, I guess what you do is you go, well, whatever you think, doctor, and leave them to
That's
it, which
right.
is is the opposite of what we're trying to achieve here.
Yep. Because patients still have to make decisions. So now they're making decisions based on incomplete or misunderstood information. They don't have the option of opting out. So they're opting in with uncertainty and not the full picture, which creates fear, anxiety. I mean, it's this panic of not knowing what to do. So I think there's some definite real world consequences, some big real consequences with this gap that exists. I think on maybe a smaller level, there's a patient safety concern if they don't understand how to take a medicine, or they're taking it wrong, or they don't understand the risks. They may be making decisions without fully understanding what the consequences are. Or they might be, feeling disengaged entirely because of that overwhelming feeling. So, whether it's in a healthcare setting or clinical research setting, the impact of not having information that they can understand and process to make informed decisions is a significant impact.
No, I totally agree. I mean, another classic example is, and you see it all the time on medicine bottles, take this twice weekly. And the number of people that take it every 2 weeks instead of twice a week, because it's just not quite clear enough. So
Yeah.
it is something as simple as that can have devastating consequences.
One of my family members was diagnosed with pneumonia and had to take a steroid dose pack, and it take 6 the first day, 5 the second day, and he misread it, and so he took all 6 at once instead of dosed over
Yikes.
time. And luckily
Wow.
he was okay, but he didn't feel well, obviously. It didn't work
Yeah.
quite as well as it was supposed to. But that's a simple
Yeah.
medication error in a very highly educated individual that could have, with a different medicine, gone very poorly. So sometimes it is about making decisions, but it's also about the consequences of misunderstanding, and it can be real and life-threatening, and also then cause distrust in taking medicines again. So it limits the person's ability
That's
to,
right.
seek further treatment or trust their doctor or ask further questions. And then there's also that level of embarrassment, I think, that we really don't talk about enough. When someone doesn't understand, they don't feel empowered to ask more questions. And that really leads to this space of, just more vulnerability, more loneliness, a lack of access to care, and then this continued distrust.
Absolutely right. And further isolation, which is the opposite of what patient communication is meant to be achieving. And it's not just words, right? We've spoken a lot about words and vocabulary, but there's that classic example of, and we've all seen it, where there's a picture of a baby with a big red circle with an X through it. So, and the intent is, do not give this to children. But that's often interpreted as this is a contraceptive. So women can often take drugs that is meant to symbolize do not give this to children, but they assume this means you're not going to get pregnant because there's a baby with an X through it. So, and you can understand how that could be interpreted that way. So it's I think testing is so important, because what's very obvious to me may not be obvious to you, and vice versa, or it may be completely interpreted the other way, which is back to your original point, Maureen, wasn't it? We need to listen and we need to educate ourselves on an ongoing basis, for sure.
And I think that goes across levels. That's what I think is so fascinating. So we do workshops internally several times a year, and so we learn a lot from these workshops. And what we found is when we have some of our senior leaders and some of our physicians join, they sort of get those aha moments, things they hadn't thought of. It's maybe been many years since they were in a patient-facing position. They think of things in a different way, and it's not until they hear that feedback and that real world life of what someone shares from their family member that it really opens their eyes to putting on a different hat and looking at it differently. I think it's a piece that we often lose in the rush of all the work that we do. But it's such an important element that it really can change the way you communicate.
No, I totally agree. And we've spoken a lot about patients, but there's also a clinical trial aspect. So, and pharmaceutical companies don't run clinical trials for fun. It's not that, we like to torture people for a living. It's, they are done to try and improve the medicines that we have, bring new medicines to market. They're really, really important. And the level of information that you give people throughout the clinical trial process really matters. I mean, what are your guys' experiences of the impact of poor patient information on the clinical trial setting? I mean, I know you guys are working very hard at Merck, so I'm sure it's exemplary at Merck, but just in general, broad terms, what could be the problems, the impact in terms of clinical trials and getting new medicines to patients?
So we see this as driving a partnership with participants, and if you don't truly enter it as a partnership, then it becomes more contractual. And so if you approach with a full view of health literacy, truly for the patient, you can drive patient-centric research. But in the absence of that, you hand a participant a contract that looks black and white. You don't have patient retention because maybe they're not understanding what's the material that they're given. You degrade trust in clinical research because you've now kind of made them a participant in an experiment, let's say, instead of really being, partnership in the research. So we view approaching a patient-centric research as building trust, really, with the clinical research foundation that we've built.
And it must take a lot of time and effort and cost to do this properly, to create a proper informed consent form, patient materials for trials.
It's a commitment. It's a
Yeah.
commitment to the principle of the participant being at the center.
But do you find that you get a much better retention rate, adherence rate? I mean, obviously you must consider it worthwhile because otherwise you wouldn't keep doing it. But has that really struck home with you? Because a lot of my clients, the question I get is, well, we don't have that many problems. I'm sure it's fine. I'm not sure it's going to make that much difference. So, yeah, I mean, what's your view on that?
There's a drive for looking for ways to get metrics. We get this all the time, and I don't think we've cracked the code yet. So right now we're basing it off of principle driven, that we're doing it because it's the right thing to invest in this type of research. So yes, it's a big commitment financially, but also the resources that go into it and the effort to move the needle to do better and do a different way. So I think the industry doesn't have an answer to that question, Lisa, yet, of what metrics do we have available. But we're at the point where we need to start thinking of what is going to be that driving evidence that's going to continue the investment. But do I dare say it's a little bit of fun too? I mean, in some of these health literacy elements of putting yourself in the shoes of the patient, of what would you like to see if you were a patient? Contract, black and white, sign here, or something that really is engaging with colors and pictures, call out boxes and headers, and really helps you understand really what you're signing into, and the gift that you're giving to research in general of the information that you have to provide. So yeah, it's kind of a fun space to be in as well. You feel a little artistic, a little graphic designer, and the end product is truly inspirational. When you see it, when you can create that conduit of scientific information in a meaningful and comprehensive way.
I think it's a great question too, Lisa, because the value is the piece we didn't layer in when we started doing this work. How are we assessing if it's working? And so there have been organizations that have done surveys and tried to collect that feedback. But I think as an industry, we can do more. And I think there are some efforts ongoing now to really try to reach out and find out, is all of the work that we're doing reaching participants, and is it resonating with them? Is it changing the way they live their lives and they interact with research. And we don't know the answer, but it's an important answer that we need. We need to ask the right questions and make sure that we're actioning the feedback. And if we are not doing it in exactly the right way or in the best way, then being able to pivot and adjust so that we can reach people. So we may assume that everyone loves a QR code, but maybe that's not really as meaningful to certain generations and communities. Or maybe an URL and an email address, maybe those are really helpful for certain industries or for certain areas or certain people with certain conditions, but they're not necessarily the way to reach someone who's in a, an older adult trial. So I think that the value piece is what we really need to focus on as an industry. And what I love about this is above competitiveness. This is pre-competitive or not competitive. It's about how do we do better for participants and for patients and across the world. So it doesn't matter where you work. We all want to serve patients. We all want to see people get well and stay well. And so I think this is a really opportunity for us to partner together, regardless of what organizations we are a part of, and assess this value and make sure that what we're doing is working. And if it's not, find a way to change.
Asking the right questions and listening, like what you said before, Maureen, comes back to that listening of what's really helpful and are we hitting the mark?
Well, I mean, I love everything that you both said. It actually has given me goosebumps a little bit. And kudos to you both. I think it's fantastic to hear so much passion and the real reason behind what you're doing from thought leaders in this space. I think it's fun. It's really, really heartwarming and wonderful to hear that, because the pharmaceutical industry gets a bad press often, literally has bad books written about it. So it's actually, and that's not been my experience in, over 25 years working with pharma. So I think it's really nice to get the real feeling of people who are doing the job out there and to explain that to all of our listeners for sure. But to go back to what you said, Elizabeth, I was smiling because, medical writing is not actually meant to be much of a creative art or science, but we get to do a bit of that, right? We get to kind of think with our colors and get our crayons out and decide how we want things to look. So I love it for that reason too. But Maureen, I wanted to come back to something you said about different demographics, and you mentioned maybe older adults and how to reach them. And we can add on, people with disabilities, people with visual impairments, cognitive impairments, and obviously, children, young people. There are lots of different people, different patient types out there. How do we have different strategies for communicating with those different patient types? What are the kinds of things that you think about when you're trying to put a message across or trying to get some information across to those different demographics?
I think it's a great question, because we do have sort of a standard way of doing things, but being adaptable is important. And I think one of the pieces is the patient engagement. So whether you have a patient engagement a section or a department in your organization, or you're just doing this on your own, it's that listening piece of getting insight into what the culture and community that you're looking to serve needs and wants. We did a couple of patient panels, and we heard from some of the patient panels, there were several older adults on there that said they would never click on a QR code. And it really struck me, because after COVID, I thought all of the menus were in QR codes. Everyone was sort of used to it. But there was this fear that they would be collecting information from someone's phone. And it never really kind of occurred to me. And so now I'm really thoughtful about that. I think the other thing that we think about when like working with communities or different people with certain conditions, screen readers and things like that, when we write information, we should really be testing it for how it is read aloud. Because the way we write some things, if you have a compound that starts with 2 letters, a dash, and some numbers, that's an investigational product. It's not read that way by a screen reader. And it can really be very confusing and awkward and difficult to understand for someone who isn't able to see the screen clearly and is really depending on that audio piece. I also think that audio piece is important when we talk about how do we pronounce medicines and really complex terms. That can be really daunting for people, that not being able to pronounce, some of these really difficult generic names for drugs. We're asking people to take this medicine and they have no idea how to even say what the word is. And I think we have a real opportunity to help people to understand how to say the word, either whether it's an audio file or a pronunciation guide, and really asking communities what's the way, what are the needs that they have, and how can we serve them better?
It's a great point, because most of us read by saying the words in our head, right? So if you can't pronounce the word, you kind of hit a mental brick wall.
Mhm.
And it's, I mean, okay, by definition, you would hope that we have a reasonably high level of health literacy. So it's really hard for us to wrap our heads around it. But I can give you an analogy because it really struck home to me. I read The Girl with the Dragon Tattoo, the Larson book. And obviously he's a Swedish, fantastic book, by the way. If you haven't read it, highly
It's good.
recommend it. But all of the character names are Swedish names, and they're not easy to either read and certainly not pronounce. And I found that I kept like hitting this brick wall, sentence after. In the end, I renamed them all Bob, Jane, Bill, because it was the only way that I could, because I'm actually quite a quick reader, and I found it so frustrating to not be able to read quickly. I was frustrating myself, so it was the only way around it. And it just really occurred to me that that must be what it must be like with these drug names that are this long. Even though we spell out phonetically, sometimes that doesn't help very much. And then you have to remember what the phonetics was. So yeah, I think it really does matter. It really makes a difference. And long words to us in a biological and medical sense are not a problem. But to normal people, the general public out there who aren't used to reading this stuff every day, it can be a real issue, and it can be a really big stumbling block. I think
And if you've got more than one drug in the study, then it sort of multiplies. So if you've got multiple treatments, especially in oncology where they're very difficult to pronounce, or combination treatments, and there's several different groups, it can be really daunting, that it blocks you from wanting to continue. And what we heard from patients when we ask about materials that they review is, I wouldn't read past the first page. And if you can't get them past the first page, then you really have missed an opportunity.
Absolutely agree. Well, we are almost upon time, but obviously there can be no conversation at the moment without mentioning AI. It has to happen. So deep breath. Anyone who doesn't want to hear about AI, just have a little bit of a snooze for a couple of minutes. But certainly in the health literacy space, it would be really remiss if we didn't talk about the impact of AI, the good, the bad, and the ugly, and where we think it might be going. I have yet to see a truly impressive health, top of the range health literacy, health numeracy AI converter tool, but I'm sure it won't be long before that happens. I'm sure that's coming our way. But where are humans still going to be needed? Are humans still going to be needed? Or are we just going to feed our complex documents in and it's going to spit out a perfectly produced health literate, health numerate document for patients? What are your views? You see a lot of these tools. What do you think?
That there's so much opportunity is what I think, but there's so much risk at the same time. And so the question, I think, becomes, what part do we want to play? Do we want to lead the conversation, or do we react to it? Because if we don't help lead it, others will be making those decisions for us. And so I think that's where we sort of are right now, is we're trying to get in front of it, and we're hoping for the best, because we don't know where it's going to go in the future. And the pressure is pushing us forward, perhaps faster than what we would go on our own. We're seeing real challenges with the output of AI in the plain language and health literate space. The tone is just a different tone than what we would naturally use to reach populations in a health literate, compassionate way that's sensitive to the situation that they're currently in, of having a new diagnosis or getting hard news, and the sensitivity that's there that has to go into health literate plain language just isn't what we're seeing being produced. We're also seeing accuracy sometimes being a problem too. So just the basic level of technical language and accuracy, reproducibility. When we're making information for patients, we need to make sure it is right 100% of the time. Non-negotiable, it has to be right and accurate, and it has to be delivered in a tone that's compassionate and with the right level of feeling. We're not there yet, but that doesn't mean that we can't get there with the involvement of the right people and helping to drive that conversation forward in the right way so that we can see good results to help us instead of hinder, this goal of patient-centric research.
I agree. And I think that accuracy is really the most important element. I think there's a distrust with medical writers sometimes when the output isn't accurate, that they want to go and check everything because if it got one thing wrong, maybe it got all of it wrong. And I think I think that piece really needs to evolve. If we're able to lead it and be, ahead of it and utilize it as a tool, I do think it has an opportunity to really speed up research, which would be wonderful. That means getting medicines to patients faster, but we need to do it in a really thoughtful way. And we can't let the speed be the driver. It really has to be the accuracy.
Amazing. I love ending on a call to action. So there you have it, listeners. Especially if you're a medical writer, get in front of AI, be part of the conversation, help lead the adoption, the adaptation, and the evolution, particularly when it comes to patient information. There are big opportunities, but obviously we need to do it in a mindful way. And it sounds like humans are still firmly in the loop for the foreseeable future, which is great for us too.
Yeah. In the loop or even in charge. We have to be driving.
Excellent. I love it, Elizabeth. Yeah, not in the loop. We are pulling the loop. This is
Pulling
brilliant.
the loop.
Awesome. Well, as always, time has gone too quickly. I love talking to you ladies, and we could talk about this topic forever. And it sounds like we actually have our follow-up topic coming that Maureen has given us on diversity, equality, and inclusivity. So watch this space for one on that. And thank you both. Thank you, Maureen. Thank you, Elizabeth, for joining TriloTalk today. You're obviously thought leaders and experts in the field. So I'm very grateful that you're sharing your wisdom and your knowledge and your experience with us and our listeners today.
Thank you, Lisa. Our pleasure.
It was a great opportunity.
My pleasure. I hope our listeners learned a bit more about health literacy and communication, and we will see you next time. Thank you so much.
Thank you.
Thank you for listening to TriloTalk today. If you have feedback you'd like to share, or if you have any ideas for future topics you'd like us to cover, particularly something you think the community should be talking about, we would love to hear it. We would like this to be an ongoing conversation with medical writers at large, and you can send us your comments on our Twitter feed or our LinkedIn page. Just a reminder, you can find all our episodes of TriloTalk podcast on Apple Podcasts, YouTube Podcasts, Spotify, and trilogywriting.com/TriloTalk. Have a great rest of your day.